Thank you, Mrs. Chair. Um, I have nothing to disclose. It's a pleasure for me to be here today and to present these results on behalf of my research team. As you all know, urinary incontinence is a prevalent condition in older women. It also interferes with healthy aging. Pelvic floor muscle training is recommended as the first-line treatment for urinary incontinence. It is delivered usually as one-on-one intervention, and because of lack of human and financial resources, its delivery is limited in many countries. This results in more invasive intervention being used as first-line treatment, putting even more pressure on healthcare system. Group-based pelvic floor muscle training could be part of the solution. It has been shown to be effective to treat incontinence in women. Group-based intervention in chronic condition has been shown to promote behavioral modification, reduce stigma, and isolation. Our pilot data in aging women with incontinence are promising. They have shown good results in terms of efficacy and adherence. To date, however, no adequately powered trial has evaluated the efficacy of group-based compared to individual PFMT for UI in older women. Therefore, the primary objective of this study was to evaluate if group-based PFMT is not inferior to individual PFMT with respect to percent reduction in incontinence episode 1 year post-randomization. The secondary objective was to compare the two interventions with regards to incontinence signs, symptoms, quality of life, satisfaction, and side effect immediately after treatment and at 1 year. Another secondary objective was to conduct a cost analysis assessment, and this was presented earlier this week. This is our study design. It was a bi-center non-inferiority randomized trial with women with stress and mixed urinary incontinence. After baseline assessment and consent, the women were randomized either into individual or group-based physiotherapy. There were evaluation immediately after the treatment and at 1 year follow-up. The non-inferiority equivalence margin was set as 10% difference between the two interventions for the percentage reduction in incontinence episode. And we needed 364 women for our trial. The population in this study were women with symptoms of stress or mixed incontinence as confirmed by the QID and the 7-day bladder diary. And you can see here the inclusions and the exclusions criteria. The individual physiotherapy treatment had 3 components. First, an individual session with a trained physiotherapist to learn pelvic floor muscle contraction. Then 12 times a 1-hour session a week, including 15 minutes education and 45-minute progressive pelvic floor muscle exercise, 1 woman, 1 physiotherapist. And in addition, the women had to do home pelvic floor muscle exercise 5 times a week. The group-based intervention was exactly the same, the only difference being that the 12 sessions were done with 6 to 8 women and a physiotherapist. Of note, those women in the group also had 1 individual session with a trained physiotherapist to learn how to contract their pelvic floor. The outcomes of our study, the primary outcome is the percentage reduction of leakage on the 7-day bladder diary at 1 year. Secondary outcomes were taken post-treatment and at 1 year, and they included the incontinence signs and symptoms, satisfaction, and complication and adverse event. This is our flow chart. 362 women were randomized, and 88% of the women completed the 1-year follow-up. These are the results regarding the demographic and the clinical characteristic. At baseline, both groups were comparable. These are the results for attendance and adherence. As you can see, attendance to the 12th session of PFMT was excellent. Adherence to home pelvic floor muscle exercise during the 12 weeks, being calculated as doing it 4 to 5 times a week, was also very good and equivalent between groups. Adherence to home pelvic floor muscle exercise after the 12 week up to 1 year, as measured as doing it at least once a week, was also good. These are our main results. You can appreciate on the top part of the slide the leakage episode on the 7-day bladder diary, initially at 3 months and at 1 year. You have the median and you have the mean, and you can see that there's a reduction at both time point and for both groups. Now, our primary outcome, the median percentage reduction and the incontinence episode was 70% for the individual group at 1 year and 74% for the group intervention at 1 year. And this was in the per protocol analysis. We did a sensitivity analysis with the ITT analysis, and we had similar results. Now, we can here appreciate the median difference between the two groups, and we can see that we are really below the margin of equivalent of 10%, which means that group interventions are not intervention are not inferior to individual intervention. Now, for our secondary outcomes, we had similar high percentage of women who reported minimal clinical important difference. We had similar high percentage of women that were much better or very much better at 1 year on the PGI-I and who were satisfied with the treatment. The need for further treatment was very low in each of the intervention, and the complication, there was no serious adverse events in any of the groups. So in conclusion, this is the first adequately powered trial to compare group-based and individual PFMT. Group-based PFMT is not meaningfully different to individual PFMT for stress and mixed UI in women age 60 plus. Policymakers should feel confident that older women with stress and mixed UI will attend, adhere, and gain benefit from group-based physiotherapy intervention. Implementation studies are now needed. I thank you for your attention, and I would like to acknowledge my colleagues and especially Melanie Morin, who's the co-investigator in the study. Thank you.
So this presentation is now open for discussion.
Hi, Chantal. Paul Hodges from Australia. I may have missed it, but did you, for the first session, was that an individual session where you assessed and then trained the muscle?
It was an evaluation that was done with everyone.
Individually?
Individually,
okay.
Yeah. And then the women were either seen individually or by group for 12 sessions.
And in that session, they were taught the
how
contraction.
to contract the pelvic floor.
Because that's going to be really important for people to recognise, is that we can't just we may not be able to throw people straight into a group. They actually need to have at least the individualised first part. I can just imagine some people might take this and think, oh, okay, just put them in a group. But the individualisation, there is still a really important individualisation.
And I, as I said at the beginning, I think it is part of the solution to help have more women being treated with PFMT, because we have problem right now that it's not all the women that are being treated. And I think that for those who can contract adequately, this may be part of the solution.
Let's just make sure that piece, that critical piece.
Well, it is in the it is in the presentation, and it was in the abstract. It will be in the paper.
Right.
Merete Tenfield from Oslo, Norway. Thank you for a nice presentation. I was just wondering about do you know why women declined to participate? Because you had 1,000 something, And there were 100 something that declined? No.
That was the investment in terms of time. There was some women that thought that it was a little bit too much to do those 12 weeks of intervention once a week, because we are in Montreal with 2 bridges and a lot of traffic, and sometimes women coming from outside, they prefer not to do it. So it was a time constraint problem most of the time.
Eva Samuelsson from Sweden. Congratulations to a very good study, and to the adherence was fantastic.
It was very good. Yeah.
Could you give us an idea, because one of your outcomes was the ISIC-USF score? Could you give us an idea of what level of the ISIC-USF was it before and after, and how much did they improve?
I don't have those data here.
Okay.
However, it would be a pleasure to show that to you. I have that in my computer. But you're talking about the ICIQ-UI, the severity.
Yes.
The severity had to be moderate to severe, because if you look at the beginning of the trial, I said that the women had to have at least 3 incontinence episodes per week. And
because they had around 1 or 2 leakages a day. You had around that. At
the beginning.
Yes.
Yeah. So it was quite severe, and then it reduces to less than 1 per day.
Okay. Yes, please.
Lena Frawley, Australia. Congratulations,
Thank
Chantal. Excellent study and great results. For the group who received the 1 individual, that was the only individual, in that session it was assessment, exercise instruction, and how to self-progress their training program, or did they get progression rules within the group intervention?
They got progression rules within the group. And maybe I can clarify something here. I think it was sufficient to have that one-time teaching, because actually we offered to those women to get additional one-on-one teaching if they required more. They were allowed up to 3. And actually we only had 12 participants that felt that they needed to see again the physiotherapist. So I think that teaching of how to contract, if they understand how to contract initially, it was sufficient. At least the women didn't want any more session, most of them, and the results are good. So.
Absolutely. So when you based their starting program on what they could do in that assessment,
we didn't base it individually. It was a protocol. So the exercise, both in the individual and the group intervention, was protocolized, and it was progressive. We published a protocol. It goes like from 6 seconds contraction 6 times in the first month in the lying, to sitting, to standing, increasing the number of repetition, increasing the number of repetition and seconds and session.
We have time for one more quick question. If that's very quick, we have time for you.
Sarah Dean from the UK. Thank you. Lovely presentation.
Thank you.
I was just interested in the adherence, which looked really excellent, and wondered how you measured that.
Okay. Depends on what you mean. The adherence to the session was the attendance. So actually, was the patient present or not?
Okay.
So that was quite easy. We had excellent physiotherapists, I must say, Melanie. We had good training and ongoing training of the physiotherapist throughout the program. So I think that was something that was helpful.
Sorry, we have to go on.
So we will